minutes for discussion.
Good morning, respected honorary delegates. Thank you for giving me this opportunity. I am Dr. Karthik from Sarojini Devi Eye Hospital. I'll be presenting a case of sarcoid hypophysitis of pituitary gland, manifesting as partial Turner palsy and game-changer role of contrast enhancement neuroimaging. A 53-year-old male patient presented to OPD with complaints of mild drooping of right upper lid, double vision and severe headache since 15 days. General examination is within normal limits. Systemic examination and vitals are within normal limits. So, on ocular examination, significant is right eye. There is 2 mm of ptosis in the right eye lids, and anter-segment examination fundus are within normal limits in both the eyes. And face is turned towards left. Facial symmetry is maintained. Ocular symmetry is lost because of mild ptosis of the right eye along with small angle exotropia. At initial presentation, extraocular movements right eye, there is adduction limitation which is -2. All the other movements are normal, and 2 mm ptosis is present in the right eye. So we have advised MRI scan of brain with contrast, but the patient refused and he consulted a neurophysician. On neurophysician advice, patient underwent MRI scan plain. This is on 26th February. On plain MRI scan, it was reported as it was a pituitary macroadenoma, which is measuring 8.7 into 17 into 12 mm. So this is the images. So patient was referred to neurosurgeon based on the MRI scan plane. Neurosurgeon made all the arrangements for the craniotomy and surgical decompression of the tumor. But before shifting him to the theatre, he ordered a repeat MRI scan of brain with contrast. So this was on 1st March. On MRI brain with contrast, it was reported that it was not a tumor but it is an inflammatory pathology. There is an enlarged pituitary gland, anterior and posterior, thickened pituitary stalk with heterogeneous post-contrast enhancement during compression of optic chiasma. This was reported. So the patient was thoroughly investigated to find out the source of inflammation. Lumbar puncture and CSF analysis was done, which have shown positive for inflammatory pathology. Serum ALP was increased, CSF proteins were raised, acid fast bacillus stain was negative, whole body scan was done, was negative for tuberculosis. Serum ACE levels were within normal limits, TSH, LH, cortisol and testosterone were reduced. Other routine blood investigations are within normal limits. You can see these are the reports. So based on these clinical and radiological serological investigations, the diagnosis of sarcoid pituitary hypophysitis was made and patient landed in hypopituitarism. So we again refer to the neurophysician. High doses of steroids were started by the neurophysician along with pantoprazole. Patient recovered from the partial Turner palsy and got relief from headache, double vision and CHP and fatigability. Neurophysician has repeated the MRI brain with contrast at the 1 month of course of treatment. So this was on 5th April. So MRI brain with contrast showed a significant resolution of inflammation. These are the extraocular movements after the treatment. They are almost full and free. So concluding this case, sarcoid hypophysitis is one of the rare differential diagnoses for pituitary adenoma. It involves pituitary stalk and pituitary gland, which closely mimics the pituitary adenoma. It is an inflammatory pathology is only when enhanced with contrast MRI imaging. This case exemplifies how important the contrast management is and guides the appropriate line of treatment, avoiding the unnecessary surgical interventions. Thank you.
Thank you, Dr. Karthik. A very, very nice case. I think there are two take-home messages there. That when you request for neuroimaging, you need to know which area you are interested in, because that's the area which radiologist will concentrate on. So that's where we have the focus on clinical examinations. You do clinical, otherwise the argument can be every patient would require neuroimaging. Why do you have to do all this clinical examination? Because so that you can tell radiologist which area you are interested in, and then once you request a neuroimaging, you need to make sure that you ask for the right neuroimaging. So here, I think because the contrast was not given initially, the first MRI.
We have advised contrast, but
they didn't give. Yeah. So I mean, because it was not done, that's why the inflammatory pathology was missed out. Just imagine if it was not repeated.
Yeah, exactly. Appropriate investigations are important. As you said, contrast is essential. there are very, very few indications for an MRI brain where I would, be willing to get away without contrast, except maybe acute trauma setting where I may just not. But otherwise, exactly, it's very, very important to note that, and of course, check for differentials. I mean, I'm not sure, we couldn't see the imaging in detail, but when in doubt, always consult with a radiologist directly as to what is the potential differentials and what is the appearance of the lesion before you take a decision on the likelihood of the diagnosis, right? So thank you very much. It just signifies the importance of a radiologist in a clinical practice of neuro-ophthalmology. So keep a radiologist as a good friend and make sure that you interact for every case with the radiologist. That is a key factor.
Just I want to know, it's a very, very good case, definitely to you and my other panelists. So in such cases, all radiologists may not, for all radiologists may not be possible to say is it inflammatory, non-inflammatory. Is there any other clue as a physician to look for if the neurologist fail? Because that if we refer the case to the neurosurgeon or the even ENT surgeons now they are doing to endoscopically, sometimes there is a tendency, they may straight away they can land up with on that line of surgery. So in such cases, is any other clue? Your is headache is there, inflammation, so ESR and any other blood parameters which may guide us?
So obviously, key first most important thing is what is the way of presentation? How quickly did the patient present with the visual loss? And of course, any associated, so a detailed neurological examination, including cranial nerve examination, is a must, because the rapidity and mentioned about the headaches would give you a suggestion that probably there may be more to it than a pituitary macroadenoma, which may be very silent. The next thing is the visual field. So what is the nature of the visual fields? If it's an inflammatory, it may not so easily just coincide with a compressive lesion where your bitemporal hemianopias may be very straight and clear. But if there is an overlap following on to the nasal field also, then that was more likely seen in inflammatory pathology as compared to pathology. So again, we come back to the same thing that, a detailed clinical examination, knowing the history and doing an examination would be essential to look for motility defects. So are there subtle motility defects? Although large pituitary and macroadenomas also have been known to be involving the cavernous sinus and then causing nerve palsies. But again, if it's an inflammatory lesion, it's far more likely that the problem, so your lesion may be apparently limited to the pituitary area, but because of the inflammation spreading to the cavernous sinus, you may have motility defect also. So these would be our clinical red flags. The moment there is even one thing that does not fit into the comprehensive picture that we have kind of made for that patient based on the diagnosis, you need to stress. But excellent, I think that was good. It's lucky that we got away with this slight oversight. Of course, I like again stress, it's important to always go back and forth again to the radiologist to make sure that you are resolving all queries that are there before you take a final decision. Thank you very much.